Well, good morning, everyone. Good morning. Good morning. I hope everybody had an easy trip into the conference today and that you implemented your best quality improvement planning and measurement and that everything is okay here in terms of getting here successfully. My name's Matthew Morgan, and I have the pleasure of being the moderator for the next 75 minutes, and we have a fantastic lineup of teams to talk to you about quality on the front line, innovative approaches to quality improvement planning, measurement, and sustaining change. And I've had an opportunity to chat via email with all the teams that have been presenting today, and you really are in for four great presentations that range from long-term care to surgical wait times to surgical site infections to partnering to improve diabetes care. We're really excited about the presentations, and we're really excited about your comments, suggestions, and questions. I can ensure you that we'll be leaving at least 30 minutes for a Q&A at the end of the four presentations. So all the speakers have agreed to speak for 10 minutes or less. We'll run through those 40 minutes for talks and then have at least 30 minutes of question and answer. And of course, that's also your opportunity to cheerlead, to say what you really liked about the presentation. So please keep your notes in mind, and we'll have a great Q&A. So we also have people from private sector, long-term care at Revera. We have people from Kingston General Hospital, the Ottawa Hospital, and Owen Sound. So the province is also well represented in this session. And just to introduce our speakers, there's some wonderful bios in your packages that you can look at. But we have Marilyn from Revera. Dana, unfortunately, will be unable to join us today. We've got David and Brenda from Kingston General Hospital. We've got Hussein and Rebecca from the Ottawa Hospital. And we have Bruce and Jillian from Owen Sound Family Health Team. So how about a round of applause for our speakers? Excellent. Just a few slides before we get going. The disclosures, there are none. So that's good to know. No disclosure of commercial support. And we do encourage you to tweet. Please use the hashtag HQT2014, and you can follow us. I'm just hoping that those tweets don't come up during the slides when they're presented during the presentation, but we'll see about that. So without any further ado, I'm going to invite Marilyn to come up to the podium.
Good morning, everyone. My name is Marilyn Gordon. I'm Regional Manager of Education and Resident Services for Region 5 in Ontario for Revera Long-Term Care. Dana Hardy, my mentor through this Residents First project, can't be here today. She's the National Director of Quality for Revera Long-Term Care. So, this speaks to the size and scope of Revera Inc. It works on the continuum of seniors living and services throughout Canada and the United States. We have long-term care in Ontario, Manitoba, Alberta, and BC. Approximately 189 sites, which is retirement as well. 73 long-term care sites in Canada, 53 of those are in Ontario, and they were the ones that went through the Residents First Collaborative. Quality improvement is in the forefront of all lines of business for Revera. Expertise and leadership in quality improvement methodologies is continually being developed and then shared between our services. Revera has the opportunity to share experience and knowledge between U.S. and Canadian healthcare locations, which enriches our capacity for best practice and positive outcomes. And we do that quite often between educational opportunities amongst our lines of business, as well as across Canada, and invitation to our U.S. sites coming up for educational opportunities. So with quality improvement in the forefront, we've really shared a very robust and enriched flavor to moving our corporation forward in that respect. And it's quite fun to be there as well. It took some time to obtain support from senior leadership to move forward with this partnership. Residents First with HQO was in existence for quite a while before Revera got on board. It's not unusual, but as we know, it's crucial to have executive sponsorship, not only agreeing in principle, but ongoing support for the project's success. In order to meet the timelines of the project and have all the homes participate, we had 3 waves of homes go through this, all at one time. The first wave had 15 homes, second 18, and the third wave 20 homes. The sessions of waves included 3 improvement facilitator sessions and 3 learning sessions for each home to bring their teams together. IFs in each home and regional faculty who learned with the Wave 1 had to then facilitate sessions in Wave 2 and 3, because as you know, with adult learning, repetition helps us to retain, and so we felt for regional staff it was really necessary for them to go through it at least 3 times, one in the learning and to facilitate in Wave 2 and 3. We chose 3 topics, all the homes. In responsive behaviors, we had 22 homes choose that topic. Falls, there were 25 homes chose that, and pressure ulcers, 6 homes. They were extremely large cohorts, and that proved to be quite challenging, and a lot of lessons learned from that. Outcomes of our experience that can't be quantified in charts are building capacity through leadership opportunities as improvement facilitators, and the team-based approach in learning sessions using home-specific data involved the Frontlines. This approach promoted time-sensitive validation of their work and efforts to improve care and services. It was imperative to develop clear aim statements. Statements that were too broad in scope, unrealistic in outcome, or not a stretch hindered the home's ability to be successful. Many homes had to revisit their aim statements to clarify their goals. The learning format of home teams allowed for networking of frontline staff at team sessions, as well as provided a forum for management and frontline to work together for a common goal of improving resident care. In evaluations by the team members, this sharing and interaction time was valuable to move the homes forward and remain very positive. Another lesson learned was that digging deeper until the root cause of the problem is found is crucial to success. Experience has shown us that we may think we know what the cause is, but until we actually track, monitor, investigate into the root of the problem, we may spend needless time and efforts on causes that don't really have an impact on the resident care outcomes. These wastes frustrate staff and managers and eventually the quality of lived experiences for the residents and their families. Lastly, we learned and supported many teams to accept failure. As PDSA cycles were completed, positive results were not always seen. Teams had to step back, regroup, decide on another change idea, and start the cycle over. It was in the failures that we really saw learning and success occurring. The success of the Revera journey of 53 homes completing the Resident First Quality Improvement Project was measured by each home and the lead team using a variety of tools. Qualitative data was obtained from direct feedback from residents and families through informal surveys and conversations during walkabouts, as well as more formal methods of structured meetings as resident council and family councils. Review of this feedback showed that the more the resident and or their families were kept informed and involved in the QI process, the more positive the feedback was. Quantitative data was completed through submission of monthly measures into the HQO website and then printing updated run charts. These run charts were shared with staff, families, and residents by posting them on their visual storyboards. The run charts were an effective visual tool by easily showing staff how they were doing in their process of quality improvement. 21 of the 53 homes, or 40%, reached their aim statements after 15 months. Revera looked at system-level success as well. Building capacity for quality improvement through improvement facilitator training develops expertise corporate-wide and truly improve the quality and services we provide our residents. And this IF training is continuing. Site-level success within each home through IF training and improved outcomes in their target topic provided a foundation to promote further conversations and QI processes to meet internal and external benchmarks. This in turn improves the quality of the life for the residents and their families. We'll go through a couple of our success story run charts. This run chart shows the aggregate data for our Wave 1, or 15 homes, 5 homes who chose falls as their focus for improvement. The red median line indicates an improvement for the home in reducing the total number of harmful falls. You'll see an initial increase of spike at the chart at the beginning of the project, which was around January 2013. This is attributed to better documentation and increased capacity of staff after training to identify and track their falls. This spike was observed in the 3 focus topics and as well in most of the homes. Again, this run chart shows aggregate data for our Wave 2 of 18 homes, 7 who chose responsive behaviors. The red median line clearly shows an improvement in January 2013 as the homes started to trial change ideas in management of responsive behaviors. At the end of the project, Revera compiled successful change ideas from all the homes and shared those ideas with all 3 focus topics with all the homes in order to provide an inventory of strategies to use as homes transition to other quality improvement processes. The next 3 slides are home-specific examples of success. And this run chart, as you can see, can instantly tell a story. This home was able to reduce their falls under the median line quite quickly after tracking 12 months of baseline data and starting their project change ideas. They reached their aim and have sustained improvements since. And so this is tracked right up to March of this year, and there are some homes that are still continuing to track with the run charts. We're hoping to get that on our corporate website to be able to use run charts. You can see very easily that this home has made great strides in reducing physical responsive behaviors on one home area. Where they had a median during 12 months of baseline data of just under 300 episodes per month, they worked at a change ideas and were able to reduce these episodes to their target, a huge 85% reduction, and have been able to keep the success going. This home's focus on reducing verbally aggressive behaviors was reached and maintained with a small blip 8 months into the project. This increase was attributed to an annotation of a new resident with excruciating pain who was not coping with admission and cursing at the staff with all the care tasks. After the resident settled and strategies were put into place to assist the resident with the move-in and with pain management, the responsive behavior decreased. This home's also been able to use the experience for other new admissions and to prevent undue distress.
You want to just conclude?
Yep, last slide.
Perfect.
Continuing to ensure IF in each home, utilizing learnings from other improvement initiatives and collaboratives, such as antipsychotic med reduction project with CFHI. Sustaining our 3 focus topics, Revera has a community of practice for skin and wounds and network for managing responsive behaviors. These groups meet regularly through virtual learning platforms. Our journey to spread our success to other focus topics, such as the HQO QIPs, will transition more positively with the knowledge and skills gained through the success of the Residents First Collaborative.
That was terrific, Marilyn. Thanks so much for that. First of all, it's great to see such a partnership between HQO and the private sector and an important player in the private sector, so thank you for that. It's wonderful to see things like aim statements and run charts, and I really enjoyed your slide on experiential learning, otherwise known as the School of Hard Knocks. So I think I'm sure there'll be lots of questions and comments in the Q&A section. At this point, I'd like to invite Brendan David from Kingston to talk to us about surgical wait times and improving them. I don't know if that always means decreasing, but it certainly means improving them. There you go.
So I'm here. Thank you.
And just one other section, there are a few seats, so here's a great time if you'd like to sit down for those at the back of the room. We'll just give you a few seconds. We've got some seats in the second row. It's great to see a standing room only audience, but come on in, we have a few seats.
So I immediately asked Matthew to move so that I could stand left of the podium, because it's obvious that I'm quite petite and I'd otherwise be just a talking
I
head.
have a feeling you're quite mighty myself.
Thank you very much for this opportunity. It's terrific to share a good news story and our experience with KGH in improving surgical oncology wait times. My name is Brenda Carter. I'm the Regional Vice President for the Cancer Program at KGH. And I'll say right out of the gates that I do not have direct budget nor resource accountability for surgery at KGH. So it's even more significant that I'm here telling this story. This is, oh my God, we've got a problem slide. And what is significant here is, and for those of you who may not know, Cancer Care Ontario measures the ability for hospitals who do cancer surgery to get patients into the OR relative to the priority coding that's set by the surgeon at the time that they see the patient. And so the target for the province, as you see on the bottom, is 90%, and that target has not changed. And in May of 2012, KGH was third from the bottom, and more significantly, we're the worst performer in the academic hospitals in Ontario. So by the time this really hit the radar, and I was asking David, we had been in this position for at least a year. And I'm not sure that we ever actually hit the target, but we had 63% of our cancer surgeries that were completed within target, meaning 37 did not. So that was quite a significant number, and we were very worried about that. And when asked the question about why was it the case that we could only get 63% of our cases to the OR, the answer was we didn't know, which was, in and of itself a big statement. We had lots of perceptions and lots of antidotes, but we actually had no evidence and no data to tell us why, let alone how could we improve it. So the gauntlet got laid down in May 2012, and we knew what work we needed to do together. We brought together a team of 6, and with visible leadership there, including myself, who was a big driver in getting us to where we needed to go. We had a very clear aim statement, and our objective was that the big team, of which there were about 75 individuals at KGH, who had anything to do with getting the patient from the decision to treat using a surgical intervention to the OR. That team didn't know, they didn't know each other, number one, because we were spread all over the hospital. So we were very clearly laying out that we wanted to be 80% within target by 12 months and 90% within 18. We felt that was a realistic time frame to be able to show results and hopefully by 18 months sustain those results. We also wanted to make sure that this wasn't about just hitting a target. It wasn't about 90%. It was not about red cases and yellow cases. David will tell you a bit about that. It was really about the patient at the end of this particular decision to treat to getting to the OR. We wanted to make a difference to see could we really shorten their journey. Again, we wanted to bring that big team together so that they could get to know each other and knew that they had a very significant role individually in helping us solve this problem. The other thing that we believed we knew was that we had not very good data, and that one of the big jobs was to be able to clean up that data so that it was a true representation of where we were at any point in time. The other thing that we really wanted to do was make sure that whatever we could create by way of tools and capability and new processes, that we could sustain our achievement once we stabilized what they were, and so that it just became the new way of working. So this is this tells the story, in that the yellow, the blue flags are really where we were by 12 months and 18 months. And you can see the general trajectory here is that within 11 months, actually, we got to 80%. And within 18 months, we were at sustaining above 95% achievement in really getting our patients to the OR. So I'm going to turn it over to David, because he can give you the detail on what exactly did we do.
Hi everyone, so my name is David, project manager in the cancer program at Kingston General Hospital. And I guess one of the things that we should talk about here is what you see on the graph is that we were able to achieve the wait times target about 94 to 95% of the time. But what does that actually mean in terms of expediting access for the patients to get to the OR? And I'm happy to say that prior to the start of this project, our median wait days were in the 25 to 26 day range. And currently they're at 22 to 23 days. So that's our median range. If you look at our 90th percentile days, prior to the start of the project, we were looking at 59 to 60 days. And currently we're consistently looking at about 51 days. So we're proud of this real improvement that we have seen. This was more of a grassroots approach. It wasn't us walking in and saying, we know everything and we know how to make this big change, and from now on this is the way we're going to do things. What we did is actually we engaged the staff, the surgeons, to get their ideas, and it's doing that actually made the change for us. So when we look at that graph, we see our ability to meet the wait time target. 94 or 95 is what we saw. It's actually our ability to meet 4 different wait time priorities, which accumulate up to that larger percentile. So we're looking at priorities 1, which is cases that need to be done within 2 days, priorities 2, which is 3 to 14 days, priority 3, which is up to 28 days, and then priority 4, which is 29 to 84 days. Lots of technical details if anybody wants to follow up with me on those afterwards. As Brenda mentioned, we did have a bit of an issue with data quality at the start, and explaining those priority codes and how they worked and how they were to be assigned was a major part of cleaning up that data, getting good quality data. One of the reasons why it took us a long time to see the improvement is because we got out and we met with the surgeons and reviewed case studies with them. We used benchmark provincial data to show them how the distribution of those priorities should be based on the disease sites that they were operating in and based on the specific procedures that they were looking at. So with good quality data and understanding of how to prioritize our cases, we moved into the next phase, which was we didn't really like looking at data which told us how we performed the previous month or the month before. We found that was too slow for us. We wanted to be able to be proactive with it. So we actually created a report which tells us, and I can pull this up anytime, in real time, how many cases on our wait list right now are scheduled to be done within target and how many are scheduled to be done outside of target. I can tell you how many days, I can tell you how long they've been waiting. That type of information is what really helped us drive the improvement. So we pull up that report on a regular basis. We go through it and we troubleshoot any of the cases that are going to be actually done over target. And like I said, this was a grassroots approach. It's from using this report that we came up with all these little ideas which helped us to see this overall big improvement. And a couple of quick little things that I'll share with you about that. A couple of ideas that came out where we were giving we have one lung surgeon for surgical oncology. His cases on average take about 5 hours to do. We were giving the guy 7.5 hour days to do his cases. So with 5 hour case, you have 2.5 hours left over at the end of the day. He came to us and said, you know what, I could double my throughput if you guys gave me a 10 hour day. So we worked with the OR, we worked with nursing, we worked with anesthesiology, and we were able to manage the schedule in such a way so that now our lung surgeon is doing 2 cases a day, effectively doubling his throughput. Another really neat idea that we that came up with us was one of our surgeons brought it to our attention that every morning in our OR, we have between 2 to 3 hours of time that is designated for emergency cases that may have come in over the past 24 hours. And a lot of the times, that time actually wasn't being used. So we were able to work with our patients and have them agree that if they were done on a standby basis, we could actually get them moved into the OR sooner if they came in and were willing to wait to see if that time was available. So it's making all these little individual changes at a grassroots level that led to this massive change that we ended up seeing. Finally, we created a dashboard to provide us, it's kind of small up there, happy to talk about it afterwards, to provide us with, at the end of the month, key measures on how we're actually doing in meeting that target and break down things a little bit further. One of the big things that I'll show you here is the second from the bottom graph, which is our throughput ratio. And what that is it's the amount of cases that we've taken on versus the amount of cases that we've been able to do in that past month. It shows us if we're managing supply and demand in a way that we can actually clear the cases off our list that we currently have. So with that, I'll pass it over to Brenda for lessons learned.
I know we're essentially out of time. But I just put this up because it is a bit of the, what did we observe at the end of the day besides good data? Is, you know, to highlight a few here, the leadership support was essential. And I wasn't kidding when I said I don't have accountability for the OR resources, and anyone who works in the hospital knows how precious they are. But we had a fantastic partnership with the surgical program, total buy-in that we needed to get where we had to be to make it possible to get patients to the OR. And the other thing that we did was we definitely walked in the patient's shoes, brought people through the OR who had never been in there before. And I think at the last point there around analytical tools and accountability definitely go hand in glove. And, you know, we see these reports, I still see them on a weekly basis. And I believe me, I don't take it for granted when we continue to sit about 90%, because I celebrate every time it hits my inbox. So thank you very much, and I look forward to the questions.
Thank you, Brenda and David. That was fantastic. It's always great when you see that measuring matters, and it mattered obviously in many ways, including identifying other opportunities that resulted in a large-scale improvement. So thank you for that, and I'm sure the people waiting for surgery in Kingston are thankful of the work that you've done as well. We're going to move on now to Hussein and Rebecca from the Ottawa Hospital, who are going to talk to us about their quality improvement work around surgical site infections.
Great, thank you very much. So it's a real pleasure to be here today because I'm pretty excited about what Rebecca and I are going to present to you. You see it's about surgical site infections, but the approach that we're using is actually something that's transforming the way we are improving quality across our Department of Surgery. And in fact now, Department of Medicine, ICU, people like that are starting to use this approach within the Ottawa Hospital. The reason why we're talking about surgical site infections is because of this. So this is NSQIP data, and I know Health Quality Ontario is planning on rolling this out into more hospitals, but basically what this shows you is if you're on the side that we're on, that's the bad side. All of those little lines represent a hospital, and this is all across North America. And as you can see there, there's very few hospitals in North America that had a worse SSI rate than we had. So this created, when you talk about change and John Cotter and what he talks about, this created our platform, our sense of urgency. But what was interesting is that we were identified as being in the 10th decile, obviously, but we didn't really move that much. It moved down a little bit by measuring, but we didn't actually move out of the 10th decile. And I think, no quality improvement conference is kind of complete without a Don Berwick quote, but, a system produces the results it is designed to produce. And I think the reason why things weren't moving is because the system we had was a top-down approach. There were a lot of thoughts from, I guess, up high being handed down saying, do this, do that, and it wasn't making a difference. And, we talk a lot about, so we needed to move our SSI rate, and we talk a lot about culture, and we talk a lot about culture within the aviation industry, within medicine, obviously. This was a great article, April of this year, Harvard Business Review. Harvard Business Review always has some really nice articles on health, if some of you haven't read it. This one was really interesting. They looked at 60 multinational corporations, and they looked at this culture of quality where the employees, and this was rated by employees, said, they felt this culture. People talked about quality. They felt that they could speak up about quality issues. And what they found is that, sharing best practices, training, monetary incentives, all these things, we talk about sometimes even within healthcare, actually were not significant. Okay, what was important to create that quality was employee ownership, peer involvement, leadership emphasis, things that I'm sure all of you are familiar with. And so in looking at our issues where we need to drop our SSI rate, we also need to improve our culture. There's a ton of studies out there. I could do a whole presentation on improving culture, improving outcomes. I'm sure all of you are aware of that as well. So we needed to kind of twin the two of these together. And so serendipitously, ended up going to this NSQIP conference, hearing about CUSP, Comprehensive Unit-Based Safety Program. Essentially what CUSP is it's a multidisciplinary team. All of you are aware of using these teams within your settings. It does have an emphasis on having a senior leader in terms of the person who sits on my CUSP teams in general surgery is one of our senior vice presidents. And it involves residents, it involves physios, it involves housekeeping. It pretty much involves anyone who touches the patient. And actually now we're actually going to include a patient on our team as well now that we've kind of got things rolling. So this is what we used. But within that, we also created an infrastructure. So we do have a guiding group, the CUSP executive team, which kind of makes sure that everything is aligned with the hospital vision, as well as keeping an eye on what's going on across all our CUSP teams. We started out by piloting this with 3 CUSP teams about a year and a half ago. We're up to 16 CUSP teams now within the Department of Surgery. And our CUSP teams are really the heart and soul of what we're doing. That's what's engaging our front line. And that's what's creating the change that you'll soon hear about from Rebecca. The other important change we made to the infrastructure is that we include quality improvement coordinators on each of our CUSP teams. And that helps, I think, I'm not very articulate, but I guess to professionalize our CUSP teams in terms of, as a surgeon, I may not be familiar with a PDSA cycle, but having someone like Rebecca on the team helps everyone on the team make sure that we're following quality improvement kind of guidelines. We also have a logistics groups which makes sure that we can implement things logistically in a feasible way. And then we have a CUSP advisory committee where everyone meets so we can share our lessons. So I'll hand it over to Rebecca. One final thing I want to mention, you heard about failures this morning, and I think what we're starting to see is that, not every intervention is going to work, but now we have the infrastructure, and to use a hockey analogy, we're able to take shots on goal, and not every shot is going to go in, but now we have the opportunity to take those shots. So I'll hand over to Rebecca.
So over 12 months, we started 16 CUSP teams and working groups, and we have over 170 individuals involved. One of the first steps that a team does is conduct a 2-question survey, which is part of the CUSP method. It says what could cause harm to the next patient and what could be done to prevent that harm. And asking that of frontline providers, we got over 300 responses and so many great ideas for improvement. And so we have 51 interventions, most of which are targeting SSIs, and these were based on ideas from frontline providers through that survey. And we know that SSIs are a very difficult thing to improve. They're very complex, and there are many risk factors. So we know we need a bundle of interventions. There's no one intervention that's going to reduce SSIs. So the CUSP approach lets us have the front line define what goes in that bundle, because we need a bundle anyway. I'd like to walk through one example now to show you how the infrastructure we have helped us to test and implement these interventions effectively. So we're going to look at patient warming. Having a low body temperature or being below 36 degrees creates an increased risk for a surgical site infection. So by warming patients before surgery, we can reduce the temperature drop that happens when they have anesthetic. This came up in a lot of the surveys for the different teams. At the divisional level, people started talking about it. Then we came together at our advisory committee and learned that multiple people wanted to work on this, so we said, let's work on this together through a working group across all the surgical services. We then had frontline providers test the logistics of the change in just a few cases. We found out things like we need to be clear what temperature to set the blankets to because they have multiple temperature settings. Our executive sponsors were very helpful in things like having facilities move electrical outlets so that we could actually plug them in outside all of our operating rooms. And the implementation group helped with things like cost. So if we're using a warming blanket on every patient, we do 27,000 cases a year. That's a lot of money, but we use one post-surgery anyway. So if we can just carry the same blanket through, we won't use additional funds, but the funds there are still something we have to track. So this is our process measure of normothermia, so having a normal body temperature at the end of surgery. Our baseline was about 55%. We're now up to 65% and pushing for further improvement. Along the bottom, you can see the changes that we put in place along the time axis there. Thank you. And we're also looking now to more accurately measure body temperature, so we expect a further increase because we're using more accurate thermometers now. Another success we had was with antibiotic redosing. Cefazoline's used in 88% of our cases, and if there's 4 hours or more between the first dose and the surgery end time, you need a second dose. We were at 50%, not where we wanted to be. So with the introduction of manual timers and then electronic timers, we were up to 90 and now 95% on time. This shows the story of our journey from the beginning of NSQIP to now. This is our unadjusted SSI rate, so this is not comparing us to any other hospital, this is just the percent of SSIs at the Ottawa Hospital. We saw an initial decrease from just having the NSQIP data, probably from awareness of telling us what our rate actually was. But then we had that plateau, and the second decrease there is when we started our improvement program. So we think that combining high quality data with an improvement method is a good recipe for perioperative improvement. These are our lessons learned, including the front line. It was a big culture shift and it wasn't always easy. Happy to talk about how we did that, but it was very valuable in creating momentum for change. And also just the improvement ideas that people have are the best because they're the ones who work with patients every day. Having multidisciplinary teams is very important. We can solve problems like who's going to put the dressing on the wound at the end of the case. Normally some of those interdisciplinary discussions can be where improvements fall through. The infrastructure, as Hussein said, allows us to continue taking shots on goal. We now have an infrastructure where we can work from the front line to the executive level and in a coordinated fashion. We hear quotes from nurses like, "Now I have a place where I can take my ideas." And the use of quality improvement methods, specifically with the quality improvement coordinators being involved, was key. This made sure that we were testing changes before implementing, measuring to know that it was effective. And if we could do it again, we would have a bit more quality improvement training for all of those on the CUSP teams. And that is the end of our presentation. We look forward to your questions.
Thanks so much, Hussein and Rebecca. That was great. High performance teamwork. I think many of the people in the audience are focusing on that and how to achieve it. So I bet you there'll be some questions about CUSP and teamwork and how that was used as a vehicle to achieve high performance. Now, there are still some people standing at the back of the room. For those of you who have a free chair next to you, you can just put your hand up. And if any of you would like to sit down, you now know where we have a navigation system available to you. Cost us a lot of money to implement this, but we got it done. All right, that's great. Okay, so now it's my pleasure to introduce the last of our 4 teams, Bruce and Jillian from Owen Sound Family Health Team, who are going to talk to us about improving diabetes care. Thanks.
Thanks very much. Good morning, everyone. We're going to move from long-term care and hospital care now to primary care. My name's Bruce Stanners. I'm a family physician with the Owen Sound Family Health Team, and Jillian is a nurse who's been with us for many years and now has just graduated as a nurse practitioner. I'm going to be speaking on our pre-diabetes program, the primary care diabetes prevention program, and then Jillian is going to speak about our diabetes program. The program began quite some time ago. In 1996, the National Institutes of Health in the United States supported a study to look at diabetes prevention, and they went with the Diabetes Prevention Program Research Corps at the University of Pittsburgh. In 2009, a study was released, 2002, a study was released that had involved 27 centers across the United States looking at diabetes prevention, and they enrolled over 4,000 people in this study and put these people into 3 groups. The first group were given regular lifestyle intervention. The second group was given metformin, a medication used in diabetes, and they were given it at a dose of 850 milligrams twice daily. And then the third group were given a more intensive lifestyle intervention. And at the end of 2.5 years, the group that was given medication reduced their incidence of diabetes by 31%, but the group that was given intensive lifestyle intervention reduced their incidence of diabetes by 58%. So the University of Pittsburgh then went on, after a 10-year study showed that the incidence was still remaining low with the continuation of the program, and they offered this program actually around the world. And the Ministry of Health in Ontario picked it up, and in 2011, we were one of 6 family health teams in Ontario to start this program, which initially was a 2-year program, but was extended to now until this coming March, and we're hoping that it will continue on even further. This shows a referral form that we put into our electronic medical record to allow the primary care practitioners to refer to our program. We have 2 lifestyle coaches, one who was hoped to be here today, but he got stuck up in Owen Sound because of the snow. And they actually run the program. The way to qualify to get into the program is to either have prediabetes, so your blood sugar levels, you either have impaired fasting glucose or an impaired glucose tolerance. Metabolic syndrome, which is a condition of truncal obesity accompanied by hypertension, dyslipidemia, and or an elevated blood sugar level. And more lately, the ministry has allowed us to use a CAN risk table, which if you score above 33, then you're allowed to be into the program. The program structure runs on 22 sessions. The first 12 are offered weekly by the lifestyle coaches, and then they go into a maintenance phase where there are bi-weekly sessions and then monthly sessions. And once the 22 sessions are finished, the coaches have been offering a program once a month for so-called graduates. As it says here, the session topics include healthy eating, physical activity, problem solving and dealing with social cues, healthy behavior strategies, stress management, sedentary behavior reductions, and mindfulness. The sessions are taught in groups that last an hour, and they often have an exercise component before or after the sessions. And some of the results, the Ministry of Health set up the program at the beginning based on the original study in the United States of trying to achieve a weight loss of 7% and achieving an exercise component of 150 minutes per week. And this was some data that they pulled from 2013, showing that almost 38% of people achieved the weight loss reduction, and 43% achieved the physical exercise component. These charts up here show some relevance to diabetes. At the beginning of the program, the A1C levels were 5.9%, and they reduced down to 5.7%. And fasting blood sugars as well were reduced over the course of the program. Average weight loss in the program was a loss of 10 kilograms, and waist circumference was reduced by 10 centimeters. Overall, our diabetes rate has been less than 5% in this program. I'll let Jillian speak.
So the Owen Sound Family Health Team provides primary care for 35,000 patients, of which nearly 2,900 have diabetes. Beginning in 2009, 2 separate physician offices developed processes to improve the care of patients with diabetes after recognizing their challenges in providing quality diabetes care. The one physician that I was working with at the time said he was doing a really poor job. Patients had poor blood pressure control, their lipids were out of control, they were not getting labs done regularly, eye exams weren't being done, foot exams weren't being done. We were really doing a poor job. So over time, the processes that we've developed since 2009 evolved into planned diabetes days, where patients with diabetes are grouped into cohorts and seen at quarterly intervals. Through standardization of processes, a team of nurses, physicians, and clerical staff offer all patients with diabetes access to consistent, comprehensive diabetes care every 3 months, with the goal of improving their health and preventing complications. And as of 2013, all 20 physicians at the Family Health Team participate in these days. So overseeing our diabetes days and the overall management of diabetes care at our family health team is the Diabetes Action Team, which came together in 2010. This team consists of a diabetes nurse educator, a physician, a nurse practitioner, a dietitian, an IET expert, a program analyst, and several nurses. The team meets monthly to review processes, measures, goals, and implement change ideas. We use the power of our electronic medical record to standardize data entry and build in reminders to ensure consistency of care, as well as to facilitate our evaluation of our data evaluation. Our IT expert, who sits on the Diabetes Action Team, created a comprehensive diabetes encounter form recently with built-in reminders, links to requisitions, links to in-house and external referrals, and as well as a diabetes custom form to enable ease of use with the click of a button. To reduce duplication of local services, our team formed a collaborative partnership with our local hospital-based Grey Bruce Diabetes Program, resulting in improved communication as well as improved access, as these diabetes educators are now able to provide their services on site to our patients. Having an interprofessional team committed to and passionate about the care of patients with diabetes has been paramount to our success. So when planning to implement Diabetes Days, we first realized it was necessary to prepare the EMR and identify the population. This involved going through each chart and identifying who had diabetes, and standardizing how patients were identified so it was consistently searchable. We also learned the importance of determining and communicating the roles and responsibilities of the nurses and physicians providing care during these visits, as well as the importance of identifying staff learning needs and addressing those gaps. One of our next steps in our quality improvement journey is the development of a patient family advisory committee, which we are currently doing to improve engagement of patients in their care. So, for example, a practice size of 1,500 to 2,000 patients would have a diabetes clinic day seeing approximately 50 to 60 patients, who are booked every 20 minutes for a 20 to 30-minute appointment. Patients are booked 3 at a time for an 8-hour day. A minimum of 3 nurses and 1 physician are present, with a minimum of 3 to 6 exam rooms. Not all patients are interested in or want to attend clinic days, so they are booked into regular episodic visits. Prior to each day, patients receive an automated phone call reminder reminding them about their upcoming appointment date. And during the actual clinic visit, patients are first seen by a nurse who's responsible for the initial history and physical, reviewing medications, labs, goals, and education needs. The physician then comes into the room and reviews the information and finishes up additional items. So reporting and identifying goals and outcomes and process measures has been an important part of our efforts in identifying areas that we need to improve upon and areas of strength. One of the ways in which we communicate with the physicians about how well they're doing is providing quarterly reporting of measures such as these so that they know where they can improve. Patients are also provided with report cards, providing them with information about their blood pressure, their own LDL and A1C, along with a comparison between their current and target value for each measure. This has helped us to engage them in their progress and improve their involvement in the parameters that we monitor. And that's everything. We welcome any questions. And if you'd like to speak about specifically how these days are run, we can speak to you afterwards. Thank you.
Thanks so much, Bruce and Jillian. When you're trying to improve the care of an entire population, I'm always underestimate the amount of work you need to do to identify everybody, not just some patients. And clearly, your approach is focused on identifying everybody and the opportunity to improve care for every patient with diabetes. Well, that was fantastic. First of all, an acknowledgement. A great Prime Minister of England stood up in the House of Commons one day and he said something like this: "Mr. Speaker, honourable members, I didn't have time to prepare a short speech, so you'll have to listen to a long one." I just want to thank all of the teams for really taking the time to prepare a short presentation. That was very impactful, so we all know that takes a lot of work, so congratulations on that point. So before we open the comments and Q&A section, I just would like to know a little bit more about all of you. So in the audience, so with a show of hands, How many of you, is this your first quality focus conference? Show of hands. Excellent, excellent, okay. And in terms of your primary role in the organization that you come from, is your primary role a frontline provider? This is for all of you. So show of hands if your primary role is frontline provider, okay? So not too many frontline providers here. If your primary role is QI specialist, excellent, look at that, that's fantastic to see. If your primary role is operational management, excellent. If your primary role is student or teacher, okay. If your primary role is policy maker, all right. If your primary role, being here today, is a patient, okay. So we still got some work to do on that front. If your primary role is to give these speakers lots of money with donations to continue their work, still got work to do there too. How are we going to fund quality improvement in the era of health system funding reform? Maybe that's for another day. Okay, let's open it up for questions. Obviously, they're very friendly. You're very friendly. So we've got a couple of mics set up. It's always easier if you use the mic. And but if you want to stay in your chair, I will try and repeat or summarize your question or comment so that everybody can hear. Who would like to go first? We've got lots of time. Yes, at the very back. Stand up and shout your question.
For the first speaker,
Yep.
you showed some wonderful results, and I think with responsive behaviors. Could you tell us how you did those, how that miraculous numbers came to be?
So the question is, tell us a little bit more about what are responsive behaviors and how did you achieve such miraculous results?
What are responsive behaviors? I think everyone knows we were tracking wandering, socially inappropriate behaviors. Don't like that wording, but that's what we were tracking. Physically aggressive, verbally aggressive. And so what did we do to be successful? The first thing is to get your front line on board. And so in all the homes that were successful, they went and had meetings right on the home areas and got to know what triggered the residents. So it was that digging deeper part that was crucial to the homes that were successful. We had homes that weren't successful. Obviously, 60% didn't reach their aim at the end of the project. But the 40% that were amazingly attuned to enabling the staff to say, do you know Mr. Smith? Why is he doing that? And asking residents, it was funny. One PSW said, I ask them, what are they doing when they're doing these behaviors? Why are they doing that? And finding out from the resident, we think we know what they're doing and why they're responding to some stimuli, but when we found out from the resident, it was totally different. And so then if you can meet that need ahead of time, they won't have the behavior. And that was very, very, very insightful in all the successful homes that chose behaviors.
Great. Thanks for the answer. Thanks for being the first questioner. Who's next? Questions? Yes.
Hi, good morning. For the speakers from the Ottawa Hospital, great presentation. You mentioned you had a quality improvement coordinator on each of your CUSP teams. Is that one different person on each team? What is their role and what sort of training do they have?
So summarizing the question, QI resources are scarce resources. How did you make sure the teams had enough of them, exposure to them or access to them?
So we have two, myself and my colleague Brigitte Skinner. We're both about 0.75 to 1 FTE on CUSPO. It is quite a big allotment. It was decided it was a priority by senior management and by our department that would be. And so we have quality improvement training in a variety of different methods, including lean and model for improvement.
Maybe I'll ask a follow-up question because I'm very interested in CUSP. So how did the physicians involved react initially and later? Was there anything that did the physicians' behavior change during this time? And do you have any pearls of wisdom in terms of getting physicians involved in quality improvement?
Sure. So to answer the first question, or I guess the last part of that question is, how do you get physicians involved? It's a kind of something that a lot of people struggle with, including us. The data, I think, is key. At the end of the day, believe it or not, physicians really do want their patients to be better, in spite of our personalities, especially surgeons. So by having that data there, I think that's key. So if we have data showing that we're amongst the worst in North America in terms of surgical site infection, that strikes a chord with a lot of individuals, including the surgeons involved. So having the data there was number one. And in fact, I think one of the key strengths of this was really pushed by surgeons. So, I mean, not to take credit, but surgeons are the ones who started CUSP at TOH. And it was supported, and it was in an enabling environment where the administration also, due to this data being there, really wanted to support it, but fully supported it. And part of that support came in the form of having quality improvement coordinators. That was not my idea. I can't take credit for that, but it was a brilliant idea, because I think the whole thing would have fallen flat on its face after some time. But to create this sustainable, ongoing change, and I really believe that that's what we have now with the infrastructure that we've created, that was absolutely key. And in an era of kind of scarce resources, for example, we drop our SSI rate across Department of Surgery from 5% to 4% over 1 year. So using a conservative estimate of $6,000 per SSI, that's like $1 million right there that's saved. For 2 QI coordinators, I don't think Brigitte and Rebecca get paid that much. So it's well worth the expenditure.
Excellent. And Rebecca, I don't mean to put you on the spot, but when a surgeon starts talking about any role the way he's talking about your role, I hope you realize how much of an impact you're having. And it's great to see someone who's specializing in quality improvement having that impact. What do you envision for your future? What would you like to do in the next 5 to 10 years? Because there's lots of people interested, I think.
Personally,
Yeah.
or for QI? Okay.
In terms of your QI,
You have
journey.
stumped me. I mean, it's true. I am working on my French.
Very good.
An ongoing pursuit. I would like to see quality improvement capacity built across our hospital and across the system, and I'm really interested in ideas about large-scale change. Helen Bevan's work is really cool, and I'd like to see us apply some of that more, so I think that's where I'd like to go. But I do like working with the surgery program. They're kind of, I've done a lot of my QI work in surgery, and I kind of feel at home working with them.
That's great. That's great to hear. And that maybe we'll ask another question to all the audience. How many folks in the audience have actually had some form of QI training, any type of QI training? Amazing. How many of you have been fortunate enough to take do the IDEAS program that was just started? So we've got some IDEAS graduates. That's great. How many have actually done some QI training in the United States? Excellent to see. And Europe? Okay, so it's great. So, I mean, we have such a talented pool in the audience, and it's great to see the emphasis on QI training improving. Next question. Who has a question? Right here.
Hi, Matthew.
Hi.
I'd like to hear from the Owen Sound Family Health team about how their strategy changed when they brought on the patient and family advisory panel. And I'd also like to hear a little bit from the Kingston General Hospital group as well, because I know that they have a really strong patient experience program there.
Excellent questions.
We're literally just in the process of advertising for a patient and family advisory committee. So we applied for funding for the CFHI, and I apologize that I can't remember exactly what it stands for. But one of our mandate or one of our goals is to have this committee. We also want to do one-on-one patient interviews. So not only patients with diabetes, but also any of their family members or caregivers, as well as doing focus groups to help us understand better what we're doing and how we can improve the care. So this is literally, we're only a few months into the process. And I think we've been advertising for a few weeks now, and we don't have much interest, so we need to change our tactic. Again, it's proving to be more difficult than we thought. But I am excited to see where that takes us.
Great. And maybe we'll ask Kingston. So your leader, your CEO has executed on a vision, which I'm sure has meant a lot of important hard work by many, many people at Kingston. Would you like to share a little bit about that?
So a couple of things. I'd be very honest and say that at the outset of this initiative, we did not embed an advisor on the team. And it's interesting, as David and I were getting ready, that jumped out in a very pronounced way, that we actually did not have an advisor on our quality improvement team. So we have moved quite a long way at KGH, as you would probably know, and that is no longer the practice. It's from the get-go on the ground floor. What we did was we did indeed walk in the patient's shoes, and we tried to and I mentioned that in my remarks, was it wasn't about the numbers. It was really about trying to understand, as we looked at the individual patient and where they were. So we were very mindful of that. So that was a big lesson learned for us as we observe going forward, as we continue to fine-tune what we're doing, getting patients involved as this evolves, because undoubtedly it will be part of the way we're going to work.
Okay, excellent. And if anyone in the audience has ideas for the teams up here on how they can be more successful at engaging patients and families in their projects, please feel free to talk about it. And you have a question?
Sure.
Yeah,
Can I actually just add to something to that? So with we did not have a patient advisor directly involved on our team, but what we did do at the onset of this project, and I saw she came into the room here. We have Laura Emery, our surgical oncology coordinator, who's responsible for a whole lot of the change that we saw as a result of this project. And what she did to help understand the amount of OR time required for each case was actually for the person who's doing the OR booking, the medical secretary, was actually paired up a patient with each medical secretary and had them follow them through the OR journey from pre-op to op to post-op to help understand exactly how much time is required in order to get that patient ready for surgery, have their surgery, and then deal with post-procedure events. So, and one of the things that came out of that was we are an academic teaching hospital, and sometimes there's things that happen with the students and with our patients. And in one event, we had a few extra minutes tacked onto an OR case, and that was because the student had spent time holding the patient's hand and reassuring them that everything was going to be okay with their procedure. So had we not have done that, we probably would have overbooked that case in the OR and not allocated the right amount of time to it. So
interesting. Excellent. Okay. Other questions, comments from the audience? Yes, right up here.
I have a question for Brenda and David. I really liked your approach on using real-time data rather than historic data to develop your hypotheses and trial solutions. Could you talk a little bit more about your approach in doing that and how that drove success for your project?
So the question is really about, everybody wants real-time. How did you make it happen?
Sure. Well, we are very fortunate in that we have a waitlist tool, and I'd be happy to talk a little bit further about that afterwards. It was actually designed in Kingston, so we're proud about that. But at a regular interval, on about a weekly basis, or anytime we really want to pull the information, we are able to go in and understand exactly how many cases are going to be over target, or how many days we have available left to try to expedite access for an individual case. It was really the result of feedback that we had from our surgeons who said, you know, we can look at the data all we want, but we're looking at numbers that existed, you know, that tell us how we did in the past month. And really, we can't predict the incoming volume and the incoming type of cases that we're going to get. It's just not a predictable demand. So what we need to do is actually look at the real-time wait lists, so we can understand how many cases we have that look a certain way, you know, different disease sites requiring different procedures and different lengths of time. So it was really from the feedback that we received from the surgeons that allowed us to come up and use that tool. So happy to talk about it afterwards. It's a really neat system.
So we have about 10 minutes left for questions, and I'm going to ask the panel, each panelist, in a few minutes to answer this question. You know, what's one thing that we need to do as the big team in Ontario to accelerate best care, best health, best value? So if you were in charge for a day and money was no object, what's one thing that if we did differently, we could accelerate our way to best care, best health, best value, which is the subtitle of this conference. While you're thinking about that, any other questions and comments? Yes, way down there. Hello. How come your projects got picked? And did the organization really support them? Down the line, go ahead.
Quality improvement is in our strategic plan corporately. It's one of the pillars, so it was very easy to align the training for residents first.
So KGH has a name that's outstanding care always. So it was front and center to everything that we did. I think, I was actively involved in the project, and at a VP level, I was clearly one of the individuals that wanted to see this happen. We had great engagement from the division head of surgical oncology, as well as chief of staff at KGH and head of the surgical program, who were all surgeons. So that helped a lot. And I think we were very strategically aligned in our aim to be able to demonstrate that by improving what we saw was quite poor performance, that indeed it was a straight road to outstanding care always, and we've sustained that effort, so definitely.
For us, surgical site infections is a corporate priority. Our goal is to be top 10% North America in quality and patient safety, and NISQIP tells us where we are top 10% already and where we're not, and SSIs is definitely where we were not. So it fit with our vision, and it's on our corporate performance scorecard, which is the metrics by which the CEO is held accountable to the board. So we get a lot of support.
And a little follow-up on that. Was surgical site infections tied to executive compensation? It was? Okay, excellent. Great.
We're a little different, I guess, but in Owen Sound, our group came together as a family health team within the last 10 years. And you saw a small diagram on Jillian's presentation of a building that we moved into 3 years ago of now 20 family physicians, 5 nurse practitioners, and a very large team. And so we moved from private practices, basically, to one large group, and now we've been moving in the last few years into quality analysis and designing how well we're doing with all our programs, diabetes, COPD, and all the others. So it's quite a great move that we've moved forward to see how well we're actually helping patients.
Okay, excellent. Okay, so time to tell us how one thing, if we did differently or we started or stopped doing, it would make a difference in our journey here. Marilyn, do you want to give it a try?
Some of the LHINs in Ontario are doing this, I believe, but I think to have more discussion together with the different partners, community care, acute care, long-term care, in Durham region where I live, we used to have that and it fell apart. But I think as we move forward, we want to be able to get some data on patient experience. You need that kind of conversation to happen to see the continuum of care. It can't be siloed.
Create tables for crucial conversations. Sounds great. Next.
So, lots of things here, but
You only get one. So.
I know, it's tough. This is a really tough thing for someone who likes to talk a lot. But I think what I would say is that we would try to overnight change the role of our leaders, and that we really truly could jettison all the non-value added work and to really focus on how do we spend time and motivate other leaders and frontline staff to get involved and have the time to get involved to do quality improvement at the front line and at the point of care delivery. And I say that because I think there's an awful lot that we do. We spend a lot of time in meetings talking stuff up, and we actually don't really make change. And I think it's really where we got to go because we can't talk about it anymore.
get the wrong leaders off the bus so there is room for some new quality leaders. Next.
So I think actually what is critical is actually understanding what value add is. Because if you bring an interdisciplinary team together and you ask them each what value add is, you might get a different answer from every individual. But what unites multidisciplinary teams, of course, is being there for the patient. As somebody pointed out here recently, we do take patient engagement very seriously at Kingston General Hospital. And one of the things that we like to do as much as possible is on our project teams include a patient advisor, and we ask them, what does value add mean to you? Because that brings a central focus to all the different disciplines around the table about why we're really here and what it is that the patient truly values.
Always ask our patients and families what value add means before deciding the course of action. Excellent.
So I'm biased. You know that from my presentation. I think if I were to pick one thing, it would be to create infrastructure that would facilitate multidisciplinary frontline engagement and with the view to improve or create a culture of quality.
So there's infrastructure prerequisites to enable high performance. Excellent.
I thought you might say frontline engagement, so I made up a backup in case you didn't say that. I do
Hence
think it's
they are a
important to
team.
move the decision down to the level of the front line. The other thing I would say is making improvement part of our daily work, not an extra or an on top of. So when you get questions every day, like, do you have an extra person who can collect this data for me? No, it's your data, and you're going to collect it, and you're going to find a way in your workflow to collect it. Or do you have an extra budget to print this? And improvement, we're here to improve your work for your patients. That comes from your budget. So it's constantly pushing back and saying improvement is not an extra, it's part of our work.
QI is our business. It is the work we do to serve our patients. Excellent.
I guess in discussing frontline again, but as a primary care practitioner, one of the biggest things that I see at the moment in improving healthcare is improving communication, as was mentioned earlier. We are still in a few silos in our system, and we see in our community anyway, we need an improvement in communication between family health teams, local hospitals, and CCAC. And I think if we can improve that, and we are working on it, it will really have an impact on what we can achieve.
Communication expertise doesn't just happen. It takes education too, training and practice. So communication expertise. Yes. Last one.
So I think we need to encourage others to understand that quality healthcare is more than risk avoidance or risk reduction. You know, avoidance of morbidity and mortality. It's also more about the patient experience and how patients feel going through this process. So patients remember that more than anything. And I compare when you're buying a car, you choose the car that makes you feel good. It's a comfortable ride. It's quiet. It's warm. Comfortable leather seats. Patients, they don't have that choice when they see us. They can't choose to go with the provider that makes them feel the best. So we should all try and make sure that experience is as nice as we can make it.
The hidden potential of service excellence and really understanding the experience.
Yeah.
There's a lot of potential there we haven't used to do all the things we want to do. Well, I want to thank, on behalf of all of you, all of the panelists, and all of you for a great 75 minutes. Enjoy the rest of the conference. Thank you, everybody.